topic that we have chosen today is very, very relevant. And over the next 4 weeks, we'll cover different aspects of calcium problems and pathophysiology, including hypocalcemia, hypercalcemia, rickets, and renal tubular acidosis. Month-old boy with respiratory distress who also had hepatomegaly and cardiac failure was in fact admitted under the cardiac unit. So this child was admitted as cardiomyopathy in the cardiac unit with a very low ejection fraction. And at that point of time, when they evaluated further, they found that the child actually had prolonged QT interval and was found to have hypocalcemia. And then the referral was done to us. And what we found that this child actually had a vitamin D deficiency. And now we know how severe vitamin D deficiency can cause cardiomyopathy. Now, this was those early ages when this was not really easily available and was not really informed. So unfortunately, this child had to go on ventilator and a lot of other complications happen. But till date, also, we occasionally see patients with cardiomyopathy. So hypocalcemia is a significant cause of concern, and we need to have a proper evaluation, assessment, and management to identify in that regards. All of you can go and have a look at our website, learning.rosesociety.in, which has got a lot of information about pediatric endocrinology, including e-learning resources in the form of YouTube videos, our platform, which has got validated tools for assessment, as well as courses for fellowship programs and postgraduate programs, also courses, which are a lot of modules available. We routinely conduct grand rounds, the postgraduate lecture series, as well as specific rounds related to pediatric endocrinologists on a monthly basis. We have got publications which can be accessed both in an e-version as well as the hardcore version and the mobile application, which really allows evaluation and management of pediatric endocrine disorders very easily. So what I'm going to do today is that we'll talk a bit about pathophysiology to begin with, then we'll talk about criteria and etiology. And then from there, we'll talk about assessment, management, and finally, since this is directed more towards pediatricians and postgraduates, we'll also have some very practical questions which have been prepared in the form of OSCEs, as well as questions which will be highlighted. When we talk about calcium, what you need to remember is that 99% of our entire calcium is actually in the bones, and only 1% of it is actually available in the blood. Now, here this calcium is bound largely to substances like albumin and phosphorus, and only 50% of it is free. It is a free calcium which is responsible for the action of calcium in that regard. Now, very importantly, the anionic component of albumin, which bounds to calcium, is dependent upon pH. In scenarios wherein we have alkalosis, whether it's respiratory alkalosis or metabolic alkalosis, we will have increased anionic albumin, causing decrease in ionic calcium, resulting in hypocalcemia. So alkalosis may predispose hypocalcemia, and this is something which we often see in the setting of renal failure, where there is a subclinical or covert hypocalcemia, and once somebody is given soda bicarbonate, suddenly the acid-base balance shifts out and one develops hypocalcemia. This can also happen in the setting of hyperventilation, in the setting of conversion reaction, or also in the setting of hyperventilation in terms of when we are using excessive settings or the ventilator and soda bicarbonate treatment. Now, the calcium homeostasis largely revolves around three major organs: the intestine, which produces the chronic source for calcium; the bones, which provide the acute correction as far as calcium levels are concerned; and the kidneys, which are mainly providing the excretion, which has a minor role in terms of evaluation and in terms of management. Now, in the settings when the calcium levels go down, the calcium sensing receptor activity becomes less, and the body senses that, okay, we are less in calcium, and the primary player in the overall regulation comes into the picture, which is the parathyroid hormone. And this parathyroid hormone has multitude of effects. It decreases the urinary calcium excretion while increasing the phosphorus excretion. So anybody who has got hypocalcemia should have a hyperparathyroidism, should also have phosphaturia and hypophosphatemia. So hypocalcemia and hypophosphatemia go hand in hand. If you have hypocalcemia with a high phosphorus, you're dealing with either a renal failure or a PTH problem, or really a phosphate load in that regards. However, the major role of PTH in calcium regulation is in fact the activity of 1-alpha hydroxylase, which is stimulated by it, resulting in production of calcitriol, which is the only hormone which regulates the calcium absorption via the intestine. PTH also has an effect on the bones. It allows the calcium to come out from the bone. So PTH basically is a hypercalcemic hormone, and it acts in synergy with calcitriol. Now, in scenarios where the calcium levels go up, the body has got another mechanism, which is the calcitonin produced via the parafollicular cells of the thyroid, which decrease the bone resorption and have some effect on the renal excretion. Now, what we need to remember is that as for any evolutionary process, the body has been evolved towards preventing hypocalcemia rather than hypercalcemia. So what we need to understand is that in that setting, the hypercalcemic hormones, the PTH and the calcitriol, play a major role, and calcitonin plays only a minor role. Remember, in conditions where the complete thyroid gland is removed, there is no calcitonin, still you do not develop hypercalcemia. Similarly, in scenarios where there is excessive production of calcitonin, like medullary carcinoma of thyroid, you do not develop hypocalcemia. So the overall effect of calcitonin is mild, it is transient, and it develops very rapid tolerance. So body is tuned more towards maintaining hypercalcemia than hypocalcemia. So PTH is by far the leading figure as far as the regulation is concerned, and calcitriol may be its mediator. Now, as I said, the major chronic role as far as calcium levels in the body is the intestinal absorption, and intestinal absorption happens largely in the dairy products. It's also in some of the green vegetables. And this calcium can be absorbed through two routes. So we have the route which is basically there through the paracellular, or one which goes through the cells. Now remember, if you are taking a lot of vegetarian diet, there is more phytate which decreases the calcium absorption. So does the intake of a lot of these soda products and colas, which also will cause calcium deficiency. Now, if we talk about the calcium absorption through the paracellular route in between the cells, this is a passive process. This process is not regulated. It is not regulated by the calcitriol. So if you're taking more calcium beyond a particular level, beyond 1500 milligrams, you will have hypercalcemia, which may happen in that setting. The transcellular process through the calcium process is actually a very active process. It requires a lot of energy. It requires channels which take in calcium inside. So we have got the TRPV6, which is there in the duodenum and which is basically affected by a fasting, while we have got the calcium voltage gated channel in the jejunum. Now, calcium absorption basically through the TRPV6 usually happen in the fasting state. Once in the cell, this calcium binds to the calcium binding protein, which then takes it through, because calcium, of course, is not going to move out very easily. It has to be transported. And this cal binding protein will then shift this calcium out to the calcium ATPase channel. So this is a very active process. And the major regulator of this active process is calcitriol. In the absence of calcitriol, only 25% of calcium absorption happens, while when you have sufficiency of calcitriol, this absorption goes up to around 40%. So if you talk in that perspective, the only major role of vitamin D pathway, including the receptor and calcitriol, is to increase the permeability of the intestine to calcium. As the only role of AVP in the water regulation is to increase the permeability of the collecting duct to free water, the only role of aldosterone in regulating the sodium is to increase the permeability of the collecting duct for the sodium. So what you need to understand is that calcitriol requires calcium intake. If you do not take any calcium, you may have huge amount of calcitriol, you will still not get enough calcium. So dietary calcium intake also is very, very fundamental from that perspective. Now, as I said, renal handling of the calcium is not a major player, but it may have significant implications in making the diagnosis, as well as implications in terms of renal calcification. So of the maximum amount of calcium which is actually filtered, 70% is absorbed at the level of the proximal tubule, largely using the calcium sensing receptor. Now, this calcium sensing receptor is sensing the calcium level. If the levels are high, it says, okay, PTH, you shut down, and urine, you excrete more. Now, if you have scenarios where you have an activating mutation in the calcium sensing receptor, or there is an antibody which stimulates the calcium sensing receptor, the body, in the absence of hypercalcemia, will behave that it has got a lot of calcium. The PTH levels will go down, but the urinary calcium will continue to go up. So this will be a classical scenario of hypocalcemia with hypercalciuria, which is a very, very important condition to identify, because in this case, if you keep your calcium levels high, you will have a risk of developing nephrocalcinosis. Now, of the remaining 30% calcium which is left, a significant chunk is absorbed at the level of the Claudine one, which is the descending loop of Henle, where it acts, and Claudine defects, as we've discussed earlier, are known to cause hypomagnesemia. It's only the 10% calcium which is there in the distal tubule whose absorption, around 50% of which happens, is regulated via the PTH. So the PTH effect, as far as calcium absorption is concerned, is not significant. But this 5% is very, very important, because in somebody who has got hypoparathyroidism, PTH cannot conserve calcium. So if you raise their calcium levels to a particular level, you will risk a scenario of hypercalciuria resulting in nephrocalcinosis. So the targets for treatment in the setting of hypoparathyroidism are much lower as compared to the other scenarios, and this is something you need to be very much aware about from that regards. Calcitriol has got a very minor effect here, and we know that thiazide are going to decrease the urinary calcium excretion, while furosemide increase that in that regards. The third major player, of course, is bone, which is the chronic store and which provides acute regulation of calcium. And this happens largely in the form of this exchange with PTH brings the calcium out from the bone at the expense of bone health. So if you have a chronic hyperparathyroidism, you will have a low bone mass and you will have decrease in terms of the bone activity. Calcitonin, on the other hand, decreases resorption, causing deposition of calcium, again causing hypocalcemia, and because phosphorus also goes in, the overall process will have a problem. So now if you look at it, the effect of these hormones, you look at PTH, it increases the calcium, it decreases the phosphorus, it increases the phosphorus excretion, decreases phosphorus levels, and decreases urinary calcium. Calcitriol increases both calcium and phosphorus absorption, causing hypercalcemia and hyperphosphatemia, while also increasing urinary calcium, while calcitonin causes hypocalcemia, hypophosphatemia, as well as increasing urinary calcium. So understanding the phosphorus and urinary calcium will give you a real clue in terms of diagnosis in that perspective. Couple of words about fetal physiology. What we need to remember is that there is an active gradient of calcium which is maintained between the mother and the fetus. So there are specific channels which allow this calcium to enter from the mother to the fetus. The fetus actually has 1.4 times more calcium as compared to the mother. Most of it happens in the third trimester. Now, this is regulated largely via the placental PTH-related peptide, which is the major regulator in that scenario. Now, this gradient basically plays an important role, but there is also an independent PTH axis which is there in the child. Now, after birth, immediately you've got cessation of supply. Now, as happens for the three major factors, glucose, warmth, as well as calcium, suddenly the supply goes down. So body has to work now to produce the calcium, and all the calcium that you have stored is going to be used now. The first response, of course, is to increase the parathyroid, which is going to take off the calcium from the bone. The calcitonin level will come down, and then calcitriol will play some role. Remember, calcitriol plays a minor role in the initial 3 to 4 weeks after birth, and that's why infants born to mothers with severe vitamin D deficiency will not have hypocalcemia because of vitamin D deficiency. They will have hypocalcemia usually to beyond 3 weeks of life, which is known as a late hypocalcemia. That is because the infant is not much dependent about the calcitriol level in that scenario. So because of all this process, you may have a good adaptation. The calcium levels will drop to the nadir by around 24 hours. And by 7 days, they will become normal. And this dip is much more for preterm. And when we'll talk about etiology, Vibha will talk about how this becomes relevant from that regards. Now, calcium affects every part of the body, particularly the neuromuscular excitability. It also has a role in secretion of a number of hormones, gut motility, and bone. So calcium deficiency will result in increased excitability, causing spasm and seizures. It would have cardiomyopathy, as we discussed in the first case. It will have gut dysmotility, so hypercalcemia, will cause constipation, and hypocalcemia may cause other symptoms as well. You may have rickets, of course, if there's a chronic calcium deficiency in that regards. Now, in this background of these three major organs, the intestine, the kidneys, and the bones, and the three major hormones, the PTH, calcitonin, and vitamin D, we can classify hypocalcemia to be false hypocalcemia. You can say a condition in which there's an ionic calcium defect, which is because of chelation. There could be a PTH related problems in the vitamin D axis, or also in the sensing axis, which also affect the PTH secretion. So if there is more phosphorus load, if there is respiratory or metabolic alkalosis, exchange transfusion, particularly with citrated blood, there will be chelation. If there is a PTH problem, you will have a high level of phosphorus. This may happen because of deficiency of parathyroid or resistance to parathyroid, hypo or pseudo hypoparathyroidism. You may also have hypomagnesemia, which impairs the PTH effect in that regards. Now, vitamin D deficiency, anti-epileptic use causing inactivation of vitamin D, chronic kidney disease or VDDR1, where the production of calcitriol is defective or there is a resistance to vitamin D, will all cause vitamin D related hypocalcemia. Classical presentation will be hyperparathyroidism and hypophosphatemia. So phosphorus levels, if they are low with hypocalcemia, think of a vitamin D cause. If phosphorus is high, think of a PTH cause. Now, calcium sensing receptor defect, I've already alluded to, is a very interesting and a unique defect in which you will have hypocalcemia with hypercalciuria. So hypocalcemia could be because of ionic deficiency, because of chelation due to hemolysis, tumor lysis, blood transfusion, or alkalosis, in which you will have classical clinical picture, and phosphorus may be high in that scenario. You may have decreased total calcium because of a vitamin D related cause, because of deficiency, inactivation, chronic kidney disease, or vitamin D dependent rickets type 1 and 2. Classically, you will have hypophosphatemia with rickets, while you may also have a PTH related cause because of hypoparathyroidism, pseudohypoparathyroidism, kidney abnormality, where you will have a high phosphorus and you will have calcifications. Go and have a look at our website, and there are a lot of resources available, the courses which are available, as well as the books and the mobile application.